Let's talk for a minute about some principles of wound care. What do we want to do in the initial phases of taking care of our patient? We want to stop any further burning. So you need to get the fire off you. If your clothes are on fire, you stop, drop, and roll. If you spill hot wax on you, you've got to get that quickly peeled off. If you have a thermal injury due to a scald, you quickly put some cool water on there. The idea being decrease the amount of time that the skin is exposed to this thermal insult. Then we want to clean the wound. Here at the medical center or at any area, the doctor's office, the emergency department, where you have a clean, sterile environment, you want to debride the bulli, remove the necrotic skin, any foreign material that's on there, go ahead and wash that off and get a clean wound bed. After that, we can go ahead and place our antimicrobial or biologic agent on top of that. If the wounds are deep and need ultimate excision, we'll go ahead and excise the burn wound and cover them with either temporary allograft, xenograft, BioBrain, and then come back and do a skin graft at a later time. So the main goals of our initial burn wound care is to prevent infection in the patient and prevent further desiccation of the wound. Here are just some examples of some of the topical antimicrobials that we use. There's simple polysporin ointment or a triple antibiotic ointment that is easily purchased at any drugstore. Sulfamylon and Silvadene are tried and true burn center topical antimicrobial agents that provide an antimicrobial basis as well as a good coverage to prevent desiccation of the wounds. If you remember, the sulfamylon is a deeply penetrating type of cream with good antimicrobial coverage, but has the potential downside of causing a metabolic acidosis due to carbonic anhydrase inhibition at the kidney. Silver sulfadiazine, it does not have the same penetration as the sulfamylon cream, but has a silver moiety as well as a sulfur moiety in there, and has reasonable antimicrobial action and has very little downside other than reported cases of neutropenia, which probably are reflecting overall neutropenia of the patient's burn rather than a complication of the Silvadene cream. There's also antifungal agents that can be put in the form of a slurry or in a powder, such as nystatin or miconazole. There are certain types of biological wound coverings that we use fairly frequently. There are simple agents which are used, such as Zeroform, which is a simple cloth that's impregnated with a bismuth, which has its own inherent antimicrobial action. This can be increased in its antimicrobial coverage by putting a polysporin ointment or triple antibiotic ointment on top of this. There are synthetic coverings such as BioBrain, which is a covering that is a matrix very similar to screen that is then placed on top of a wound. This then allows the wound temporary coverage and protection from desiccation, and as the wound heals underneath this, we will see an actual eschar form on the BioBrain, for which we will lift off by applying a petroleum-based jelly. There's also Integra, which is a neodermis type of product, and Transite, which is a product that has human fibroblasts impregnated on a BioBrain type of matrix. Integra is a very special product in that it actually has a matrix and fibroblasts that are placed on this that actually incorporate into the patient's wound. This is an example of Integra. This is a silicone layer, which is a shiny layer that has been placed on an extremity wound. And what we're beginning to see here is an incorporation or an angiogenesis of the wound into the Integra. It has a kind of a salmon-colored appearance, which as the angiogenesis in fibroplasia proliferates in here, actually begins to have a more reddy color and looks like very organized tissue. When the Integra is ready to be grafted, we remove the silicone layer off this, give a light excision to the very most superficial layer of the Integra, and then graft right on top of that. We also use lytic agents, which are enzymatic debriding agents. There are collagenases that are available right now, which include santalpolysporin and Accuzyme. Santalpolysporin is used at our institution very frequently on our partial thickness burns because this does a chemical debridement in between the bandage change. If a patient has a simple sulfamylon or a Silvadene dressing applied, there is no actual debridement that is being taken place until you remove the bandage from the patient. So there's a little bit more nursing that takes place if a patient's in Silvadene or sulfamylon, because you need to clean this off and you need to do some, if you will, scraping and localized debridement of the wound. If you're using a collagenase, a lot of this is being done chemically, and when the bandage comes off, the bandage debrides the patient's necrotic tissue at that time. Much easier to care for from a nursing standpoint, seems to increase the rate of healing, and perhaps has a little bit better cosmetic outcome. If you can see here, this is a patient with vesicles or bullae due to a second degree or partial thickness burn. They're being cleaned off. Silvadene is being applied, and burn bandages are then being placed on top of that.